Hello, and welcome back to the ASCO Journal of Oncology Practice Podcast. This is Dr. Nate Pinnell, medical oncologist at the Cleveland Clinic and consultant editor for the journal. Over the last decade, we've seen a widespread adoption of electronic medical records, and as a result, there's now a staggering amount of patient information available across all cancer types that could potentially be used to learn about treatments, outcomes, and the quality of care. Unfortunately, up to now, we've not really taken advantage of this so-called big data. But many organizations, including ASCO, are trying to change this through programs like CancerLinQ. Joining me today, we have a real treat. Dr. Bob Miller, the Vice President and Medical Director of CancerLinQ for the American Society of Clinical Oncology, is here with us to discuss his paper in the JOP titled CancerLinQ Update. I might also mention that Bob is the former podcast editor for the JOP, so I want to give a special welcome back to Bob.
It's great to be here. Thanks, Nate.
So what exactly was the impetus for ASCO to design CancerLinQ, and how do you think big data has the potential to help improve cancer care in the U.S.?
Sure. Well, I think the impetus to design CancerLinQ on the part of a professional society for ASCO was really tied into ASCO's mission for promoting the highest quality of cancer care. And the ASCO leadership was inspired by writings from the Institute of Medicine and others, and this was about 2011 or so, talking about the learning healthcare systems. And I have to admit, when I first heard that concept, I thought it was fairly abstract and not particularly relevant to practice. But I think what ASCO was inspired to do was to say we have this opportunity to take the data that we're already collecting in routine patient care and put that into a system that really behaves in a way that we would want our healthcare system, we want our electronic health records in particular to work for us instead of, against us as it always seems. And it really speaks to sort of the blurring between research and practice. So research informing clinical practice and vice versa. Your question about how can big data really improve cancer care, I think the time is right for this. I think for a few years, the term big data has become a little bit of a term of art and may have lost its meaning. But, I think we're just at the point now where we have so much data to manage, right? The rapid advances in genomics and other parts of precision medicine have really just completely outstripped our ability as clinicians to manage the amount of information you need for every clinical decision. So you need the power of supercomputers and you need the power of aggregation. I think it's also the increasing recognition, well, I guess I shouldn't say it's increasing, but the recognition that only a small percentage of patients are on clinical trials. So in regular care settings, close to 95, 97% of the care that's being rendered is not in the context of a clinical trial. So that's largely being lost because the data that's being collected is trapped in unconnected servers and poorly interoperable EHRs and so forth. So ASCO's vision that it is trying to realize through the implementation and the wider dissemination of CancerLinQ is really to create a platform where these data are not lost, where quality performance metrics can be delivered to the practitioner at the point of care.
Can you take our listeners through and kind of describe what exactly is CancerLinQ and sort of how it started back to the original pilot and where has it come over time to the current iteration?
CancerLinQ really is it's a cloud-based database. It's a series of databases to be accurate. And the way it works is that a software connection is made between a practice electronic health record and the CancerLinQ database. And the data that are in the EHR are extracted basically in their entirety and brought into CancerLinQ. And that's done, I won't go through all the technical details, but that's done either by a pull method where a piece of software is installed behind the practice firewall and specific data elements are pulled out, or there's also the push method using a data warehouse or other kind of extract. Anyhow, so this is real protected health information, and this goes into the CancerLinQ database, the first database we call the clinical database, and then a series of ontologies and vocabularies are applied to sort of make some sense out of it. One of the questions we often get is there a data dictionary, or, how do you normalize the data across all the different EHRs? And that, quite frankly, is our biggest challenge because EHR data is pretty messy, and it's collected in a whole lot of different ways by in different clinical settings, and it's not clinical trial data. It's not done by a case report form or in a very systematic way. But the data do go in, and using vocabularies that are from the National Cancer Institute, Metathesaurus, and other sources, some order is put onto the data, and then the next step is the data are de-identified because you really can't interrogate the database except for your own patients if there's protected health information still in there. So that aspect, again, is done via software. I think the one thing I want to emphasize is that all of this is done, the connection is done on the back end. What I mean is that once the hookup is done between the practice EHR and CancerLinQ, then pretty much every night there's an incremental update done. And the oncologists don't see any of this. All of this is invisible. They're just entering data into their electronic health record like they normally do.
How does this actually end up working at the point of care with physicians who are participating in CancerLinQ?
Sure. Well, the way it works right now in terms of what the physician sees is this is accessed through any web browser, so it's a web interface. That does mean, this is a deficiency, it does mean that you have to have two screens open if you're going to use an exam room. You have your EHR screen and the CancerLinQ. My dream is someday that this will appear as a window within every EHR, and we have some interest in that, and it's just not happening yet. But basically, there's an interface that, based on the security rights of the individual practice, a clinician user would have different security rights than, say, an administrator. They log in and they see a series of tiles, and each tile launches a little mini app. And I think the two main things that are of interest to your listeners would be, I've alluded to both of these. One is a dashboard of clinical quality measures. So some of these are the ASCO COPI measures and potentially other clinical quality measures that are firing real time on the data that's within the EHR. The second tool is called CancerLinQ Insights, and this is a data exploration tool that the individual user basically drives. It allows you to start with your entire cohort of patients. You can run this on either your patients, your PHI, or on the de-identified aggregated database, which is the latter, is where the real power is. But what you can do is you can drill down. You can start with, show me all cancer patients. Show me all cancer patients with lung cancer. Show me all lung cancer patients of a certain stage. Show me all lung cancer patients who got nivolumab. Show me only those that are 70, and so forth. And you drill down through a series of clinical filters to smaller and smaller cohorts. And some of this is still developing, but obviously we're looking to see endpoints. We're looking for the important oncologic endpoints, survival and progression-free survival and toxicity. Some of those are much easier to get in the EHR than others. For example, we have pretty robust lab data, so I can tell you what all the hemoglobins are. Progression-free survival is a much bigger challenge. But these are things that are presented to the practitioner at the point of care. There's also a number of standardized reports, how many patients of different types. There's dashboards for administrators in your clinic looking at the quality performance of all of the other physicians in the clinic. You can't see anybody else's practice, but you can see the other physicians in your own practice if your individual practice gave you the rights to do that, and so forth. And ultimately, third-party access, so that our informatics team and others will create custom reports for qualified third parties to interrogate the database.
So this is something, certainly the research potential is incredible here, looking at all of the de-identified data across everything. But this is a tool that practically can also help your own practice. This will somehow notify you of how your patients are doing compared to certain recommended quality metrics, or even potentially point out opportunities where you can provide something to a patient that you may not have noticed.
Yeah, that's exactly right, Nate. And we've always envisioned this as delivering both of those. So first and foremost, our intended user is the CancerLinQ subscriber, the oncologist, the oncology practice. And even if they're predominantly a researcher, they still need access to this information about how are their patients doing, how are they performing. And the information needs to be actionable. That's one of the problems with quality measurement in general, and even something like ASCO's COPI program, is it's all retrospective. It tells you how you did 6 months ago on the use of adjuvant chemotherapy for stage 3 colon cancer. CancerLinQ, one of the functions is it's an early warning system. It allows you to say, oh, well, look, of my 35 patients with my practice that have T3N1 colon cancer, 33 got adjuvant 5-FU-based chemotherapy. I've got to find out what happened to the other 2, and there may be legitimate clinical reasons and so forth. So, but at least it presents this to you in the context of a metric to be able to do something about that. If somehow that patient got missed, fell through the cracks, you can intervene. The idea of looking in the aggregated database, not only for research questions, but for just if you're confronted with a patient with a rare diagnosis, if you're seeing a patient with an adrenocortical carcinoma or a male breast cancer or whatever, there's not going to be many trials. There's not a collected experience of what to do with those patients. It's not the same as clinical trial evidence, but it's evidence nonetheless. It's evidence you probably didn't have at the point of care. And again, that's the second use of CancerLinQ.
That's amazing. It really is. It's such an exciting project. Obviously, one of the powers of big data is how big it is and how many patients and physician practices you're able to incorporate in your database. So has there been a lot of interest in participating in CancerLinQ, and sort of where is it in its rollout?
There really has. A lot of this literally just happened in the last 9 months that we've been gratified, extremely gratified by the response of the oncology community because, like I said, when we started this, we weren't sure if this was something people wanted. So where we are right now is, as of the day we're recording this, we have about 70 oncology practices of all shapes and sizes, small single specialty practices, all the way up to Intermountain Healthcare, large integrated delivery networks, academic medical centers. So we have about 70 practices. That represents somewhere in the ballpark of about 1,500 oncologists. And we're closing in on about 1 million patient records. And again, to be perfectly transparent, not all of those records are curated or processed, but that's the number of records that are in the data lake right now, and they have to go through this data pipeline to make them more usable. So the response to the community has been remarkable. And, our goals are to continue to grow this. We are looking to bring on half the oncologists in the U.S. in the next couple of years. We have some plans to expand internationally. We're having conversations with a number of international centers. They have different data privacy laws in Western Europe, and so those are some things to be worked out. But certainly growth and expansion is what we're looking to do.
So where is CancerLinQ going from here?
Well, right now, Nate, we're focusing exclusively on electronic health record data because it's this vast trove of clinical data, but we fully intend to enrich that data source with other data sources. So things like genomics databases, administrative and financial information from practice management systems that are often part of the EHR. We're having some conversations with SEER for registry data. We're looking to bring in claims data. You can enhance the information about vital status of patients with things like the National Death Index and the Social Security Death Index and some of these external databases. And in addition to more data, we are kind of positioning CancerLinQ, if you will, as a convener of the oncology community. And what I mean by that is we're looking to have agreements and relationships for collaborations with sister societies, with agencies like the FDA and the NCI and SEER, and we've started some of these conversations already with other members of the oncology care team, like the oncology nurses and pharmacists and physician assistants and so forth. And we're really looking to be the place, and I think ASCO is well positioned for this being a nonprofit, and CancerLinQ remains a nonprofit endeavor. We're looking at being sort of the honest broker of data. But again, the mission is the same. It's really all about delivering insights and delivering practice-changing data that will improve the quality of care. That's core to ASCO's mission, and that's really core to what CancerLinQ is all about, too.
I think this is tremendously exciting, and I'm so glad you were able to join us today to talk to our listeners about it. And hopefully, as things grow, we'll be able to bring you back and talk about it again in the future.
That would be great. I'd be happy to.
I also want to thank all of our listeners out there who joined us for the podcast today. The full text of the paper is available at jop.ascopubs.org. Don't forget, you can also read the JOP and access these podcasts on your smartphone or tablet with the ASCO Journals mobile app available in the iTunes Store and Google Play. This is Dr. Nate Pinnell for the Journal of Oncology Practice signing off.